Dr. Cynthia Rasmussen, and I'd like to talk to you about how to start a vulvovaginal clinic. I am an OBGYN by training and spent about 8 years as the director of a vulvovaginal service as the third act in a long career. I don't pretend to be an expert about this, but I have had some experience and am happy to pass along what I know. I think the first thing that you need to ask yourself is why you want to do this. Do you want to get better at treating vulvovaginal disease in your practice? Do you want to provide a service that's not available in your area? Do you want to expand an academic program? Are you eager to teach the next generation of vulvologists? Are you interested in working with specialists in other disciplines? If you're thinking about doing this to enhance your revenues and expand your practice, well, if you build it, they will come. But be aware that these patients are time-consuming and difficult. So, and nobody makes tons of money doing this. So if this is a revenue generation scheme for you, this may not be the easiest way to do that. Are you looking for an easier professional niche for the next phase of your career? There are some ways in which this will fulfill that and some ways in which that won't. Do you want to have a purely consultative service where people send patients to you, you evaluate them, make a plan and send them back? That may be somewhat difficult because if you're able to help these patients, they get quite bonded to you and they may not want to go back to their previous provider who hasn't helped them. And do you want to do this because someone told you that this should be done and you were tasked with doing it? I will tell you that of all the people that I know who do this work, the one common trait that they have is passion. Like I said, these patients can be challenging and difficult, and you really need to have a passion for helping them. If you don't, I think that you're going to find this as difficult work. Just as an overview, we'll talk about logistics and personnel, how to structure your program and the patient experience, how to cultivate a network of consultants to help you, some tricks that we've all learned over time that will make things easier for you, and also some advice about how to make this a financially viable venture for you. The first question that you need to ask yourself is, what is going to be the focus and the scope of my new practice? You will be doing a lot of benign vulvar skin disease and vulvar manifestations of systemic diseases. So if you're not experienced in vulvar dermatology, this is a skill that you will need. Difficult vaginitis is definitely going to be a part of this as well. You have to be able to deal with recurrent disease and also treating disease in patients who, for one reason or another, have contraindications to conventional treatment. Probably one of the biggest decisions you're going to need to make is whether or not you're going to do pain work. Patients with vulvar pain and dyspareunia are going to come to you, and you need to decide whether that's within your scope of practice or not, and have a mechanism for weeding them out before they get in your office if you're not going to do that. If you practice in an area which doesn't have a pelvic floor physical therapist within 100 miles or more, then either you're not going to be treating pelvic floor dysfunction, or you may need to hire a pelvic floor physical therapist and bring them in and get them working for you. You also, if you're going to do vulvodynia and dyspareunia, are going to have to deal with sexual dysfunction, and it is very helpful to have sex therapists available for these patients because you're not going to be doing their sex therapy in your office. Menopause and atrophic vulvovaginitis is definitely going to be a part of this, both for normal menopausal patients and also for patients who are being treated for breast cancer with anti-estrogen therapies. If you have a place where oncologists can refer patients who are having sexual difficulties after cancer treatment, you will provide an incredible resource for these patients, because most or many oncologists don't feel comfortable addressing that particular issue, and your office would be the perfect place for that. Next, if you can, is either to visit other established programs or to talk to people who are in established programs. When I knew that I was going to be transitioning from gynecology and menopause into vulvovaginal work, I traveled all over the country, spending time with probably a half a dozen experts in their offices and clinics and programs, and it was incredibly helpful for me to see how other people do this work and what I would need in order to be successful. It was also my experience that the people who do this are incredibly generous with their knowledge and time, because in addition to being passionate about what we do, we also are aware that there are not nearly enough of us doing this work. So if there's someone who's interested, we are very happy to show them how it's done and help them be successful as well. We need colleagues, we need to cultivate and grow and train them, and I think that you'll find that this is a very welcoming community, and we have each other's backs in terms of helping each other out with difficult patients as well. Now, you need to decide what kind of a venue you're going to use for providing your services. Is this going to be a subset of a private practice, either in gynecology or dermatology? Is this going to be a specialty teaching clinic within an academic institution? Is this going to be a dedicated full-time program or center? Or is this going to be a multidisciplinary clinic with other providers? Or is it going to be a combination of those things? Are you going to practice in several different venues, which some of our members do? It's entirely up to you, and you may start in one place and expand into other applications as well. The first thing you have to do is to put together a business plan. And if you haven't done this before, get some help with it. You'll need to assess exactly what is the need for these services in your area. What kind of volume can you expect in your target population? How large is your referral area going to be? I will tell you, if you build it, they will come. And they will come from a lot farther than you think. I know in the specialty clinic that I ran and worked in, people came from all over the world to see us. So you can't count on that. It's not big volume, but you do need to have an idea of approximately what kind of volume you can generate. What are your qualifications? What training have you had? What are your past successes in this field? What are your program goals? You know, what's the scope of your practice? What are your objectives? And decide what your performance measures are going to be. We'll talk a little bit about that later. What are your key steps for implementation? We'll talk a little bit about that. What is the financial analysis? You really need to be able to present a budget. What's your timeline for implementation? And what are the expected benefits for your organization, the larger health system, and your patients? This should really be your major selling point. It is helpful to find a local champion, someone who is going to help to further this endeavor of yours, either within your department or academic division, within your hospital system, within your community of healthcare providers, within the community of patients and the general public, and within the fundraising community. I worked for a large multi-specialty program, and my program was in the greater Boston area, and I had no idea that they actually had a fundraising department, and it was just luck for me that the woman who was the head of fundraising also happened to be a patient in our clinic. So she was a great champion for us. You know, if you contact your colleagues in whatever specialties you think might be interested, I mentioned before the oncologists, if you can help them out with their patients who are having sexual dysfunction after cancer treatment, you know, you've got a referral source there. If you are a gynecologist practicing in an area where the dermatologists don't like to do vulvar disease, then you've got advocates there. See if you can find people who are going to be in your corner regarding this. Startup funding, you know, we're going to talk in a minute about pitching. You're going to have to pitch this, but you also want to see if there is a fundraising department that you can tap into. If there are support groups for certain vulvovaginal diseases who are willing to contribute to helping you start up a practice, there are a number of different funding sources, and you need to get a little creative about that. And then once you've got all of your information together, then make your pitch, and hopefully you will be successful. Now, once you've got the green light, you have to decide how you're going to staff your program. You need clerical support. It is a lovely thing if someone within your organization is designated as a patient care coordinator, because you're going to have new patients coming into your practice. You're going to have patients being referred to other specialists. You're going to have return patients, and they all have special needs, and it's lovely if someone can be designated to tracking down those old records, making sure that the appointments get made, making sure that the insurance approval is in place, all of that stuff. Who's going to be your providing staff? Physicians, nurse practitioners, physician assistants, some combination. Medical assistants are essential, and I'm going to talk for a minute about registered nurses. You will be using a lot of pelvic floor physical therapy and sex therapy, and there are many programs that have this as part of the staff on site, because you're going to need this so frequently that it's nice to have a seamless way to refer. If you are in a dermatology practice, do you need a gynecologist to come and help you? And if so, how often? If you're in a gynecology practice, do you need a dermatologist who's interested in vulvar disease and can help you with this? And how often do you need them? And especially someone who can do systemic prescribing, because you're going to see some pretty advanced disease that's going to need systemic medications that the average gynecologist is not trained in using and is not generally comfortable with. So decide if you want to incorporate these people in your practice from the start, whether you want to have them in the community and just to have them on speed dial. Decide how you want to structure this. We had 2 registered nurses in our program, and I will tell you that there were about 5,000 patients in our program, and at least 1 or 2 physicians and 1 or more nurse practitioners at any given time. But we had 60 hours a week of RN time just to man the phones for patient phone calls. These patients, especially if you're doing pain work, are very needy. Their pain conditions flare. They need help with their flares. There's a lot of anxiety and depression that accompanies vulvar pain, and that needs to be addressed. And these patients really need a lot of hand-holding. And like I said, it took us 60 nursing hours a week and 2 providers in order to really address that. It becomes overwhelming if you, as a single provider, need to do all that in addition to what you need to do in diagnosis and treatment. So the next thing you need to think about is, how is the patient experience going to unfold? Walk yourself through what this is going to be like for them. First, how are they going to access your service? Are you going to only accept patients who were referred from community providers? That is what we did, and the advantage to that is, number one, you get to bill as a consultant if the patients are referred, and you follow all the steps, and I'm going to talk about that later. But also, it assures that you're going to get records about what has been done before. You can get the records from the referring provider, and that's incredibly helpful, since many of these patients are not completely conversant with their histories. Are you going to allow patients to self-refer? Are you going to let them book online, or are you going to book them? And in this day and age, are you going to book them for a telehealth visit? Maybe the first their first introduction to your practice is time spent with you in a virtual visit where you nail down the history and then you bring them back for the physical exam. So there's lots of different ways to do this. And then just some tips that we learned over time. A lot of people come in with a lot of different therapies, and sometimes the therapies are obscuring what you need to see, and sometimes the therapies are part of the problem, especially topical therapies. So have the patient discontinue their topical, vaginal, and anti-yeast medications 2 weeks before they see you, so that we can actually be able to tell what's going on. Have her get a paper bag and throw all of her current and past medications into that bag so that you can actually see the bottles and the tubes and the prescriptions, so that you know exactly what she's used before. A lot of these medications look alike and sound alike, and it's going to be important to know what's been tried and what has worked and what hasn't worked. Have her medical records sent to you before the visit, especially pathology reports, operative notes, and culture results, because these are going to be critical for where you go next. It was the experience in our clinic that most of the patients coming to us, and we were a specialty referral clinic, had seen between 5 and 12 other providers before getting to us without being substantially helped. So it's really, really important to know if they've been biopsied, what the biopsy results were, if they've been operated on, you want to see those op notes, and if they're complaining of recurrent infections, what the cultures have actually shown. And then in your practice, and we're going to talk about each of these, you need a new patient questionnaire. If you're going to, this is the most efficient way to do the history. The history in these patients is comprehensive, long, and complex, and you really need to have them do that ahead of time. You need patient education materials. You are going to be spending a lot of your time teaching your patients about what they have and how to treat it, and they are only going to absorb a small percentage of what you tell them in the office. You should be able to send them home or give them access to patient education materials that they can refer to later. There's certain equipment and supplies that are unique to this particular subspecialty, and also resources that are going to be helpful for you. We will talk about all of these. All right, we had a new patient questionnaire packet before everything went online. And in that was a cover letter. You have to decide whether or not you're going to see children for this. There are certain dermatologic conditions or infectious disease conditions that will affect children, and anatomic conditions that will affect children. And you have to decide whether or not you're comfortable doing this, whether you need a specialist in pediatric and adolescent gynecology to help you with it. And it's a different questionnaire if the patient is under the age of 12 than if they are an adult. It's nice to have your questionnaire online so that the patient can access it. And if possible, have that online questionnaire that they complete populate your electronic medical record if you can do it. You need records releases, privacy and insurance forms that need to be filled out. We always included rescue tips for vulvovaginal care, basically information about vulvar skin care, because these patients come to you because they're in distress. And if you can give them some information that will help them immediately, they will be very grateful. Now, the other thing, and not everybody does this, and in retrospect, I wish that I had, you can have research sub-questionnaires, ones for validated instruments for depression, pain, anxiety, and sexual function, the FSFI. I wish that I had that as part of our initial packet, because once you start doing this and you start really getting hooked on it, you want to report what you're doing, and also you want to be able to report it to your stakeholders. And if you have a validated instrument that you can use that will demonstrate that, for instance, depression scores improved, anxiety scores improved, pain scores improved, and sexual functioning improved from before and after treatment. That's a very powerful argument for continued funding for your program, but it also will help you from a publishing and research standpoint. So you decide what things you want to measure, what outcome measures you want to track, and include that in the initial package so that you have a baseline score. A typical questionnaire is, basically it's a medical history. Demographics, where they were referred from, history of present illness, past medical and surgical histories, current medications and allergies, review of systems, family and social histories. But there are some vulvar-specific elements. What has been tried so far? Medical or surgical therapies? What lifestyle modifications are they having to employ? What devices have been used? Some patients with vulvar pain and bladder pain get implanted devices from urologists and urogynecologists. You need to find out where the patient has come from and what has already been done for her. What makes her complaint better or worse? What time of day is it worse? What specific activities will duplicate their pain? Does their problem vary with the menstrual cycle? There are a lot of clues in that. What are they doing to their vulvar skin? I will tell you that this is an amazing source of information, and it will really startle you what people are willing to put down there. What personal care products they use, what are their hygiene habits? Are they over cleaning? Are they cleaning with really scary things like Brillo pads and Lysol? And it's amazing what people will use down there. What is the impact on their life, on their sexual life, on their ability to sleep normally, and on their activities of daily living? For many patients with pudendal neuralgia, they're not able to sit. If you can't sit, you can't work. You can't go to a restaurant. You can't go to a movie or some kind of entertainment. You either stand or lie down, and that's not conducive to modern life as we know it. Have you been biopsied for this condition? When and what were the results? And this is really important. What bothers or worries you the most? This allows you to focus in on what's most important to the patient. And also get the patient's insight on what she thinks has been causing her problem. And don't neglect that, especially if pain is part of it. Do you have suicidal thoughts because of this? There are several entities that you're going to see that are just so awful to live with that the patients have considered suicide or have even attempted suicide. And if this is the case, you need to know about it so that you can address that and make sure that they have appropriate support for that. There are lots of different ways that you can do visits. In our program, an initial visit was 60 minutes, and I was never able to do it in less. And then a follow-up, depending on how complex their situation was either 15 or 30 minutes. You can have multiple consultants in a visit. Periodically, although the people who staffed our clinic were gynecologists and gynecologic nurse practitioners, we would have a dermatologist come and do joint clinics with us. And we generally, the gynecologist and the dermatologist would choose different primary diagnoses so that as two different specialists, they could both bill on the same day. In a teaching setting, you may have medical students or residents or fellows or other people with you. You may be running a resident teaching clinic in an academic medical center. There are shared medical appointments where, and we did this for a while, where in a 2-hour span of time we would book 8 patients. We would need 2 folks. We would need the RN who would spend that 2 hours answering questions and giving didactic information, and then the provider would take the patients back in 15-minute increments and do the physical exam for the follow-up appointment. We didn't do shared medical appointments for initial appointments, but we did it for follow-up appointments. And then these days, of course, virtual visits. and you'll have to decide what your own style is for that. That works well for people who are getting follow-up and are stable. It may not be as helpful for people who you really need to lay hands on. Just some tips for documentation. Like I mentioned before, if you can have your online questionnaire populate your documentation template, that's a real time saver. Smart phrases and shortcuts in your EMR, learn them all and use them for drug regimens and treatment regimens and commonly used terms. Scribes are wonderful. They do increase your efficiency, and they definitely increase provider satisfaction. They shorten your day. Not every institution is financially equipped to be able to provide you with this service, but when it's available, it's wonderful. And rather than trying to type, voice recognition software is a wonderful way to go, because you can dictate faster than you can type in most instances. Now, if you're going to use voice recognition software, it is helpful to add the following phrase. This note was generated with a voice recognition program. Please excuse any errors which may have been overlooked during the review. Sometimes these errors may affect the content or meaning of a given sentence. When you are editing this at the end of a busy day, if you miss something that really changes the meaning of what you tried to say, this hopefully will protect you a bit. Now, photo documentation is extremely helpful for vulvar dermatology, and there's several ways to do this, but you always want to be HIPAA compliant. In the early days, we had a digital SLR camera that uploaded into our EMR. More recently, my institution used Epic, and there is a Haiku app for the iPhone and Android phones, and a Canto app for iPads. And currently what we do is we bring an iPad into the room and just let Canto take the picture and load it immediately into the patient's EMR, and then it erases it from the device, so it's completely HIPAA compliant. Don't forget to get written consent if you're going to do any kind of filming or photography. Do not skip this step. This is really, really important. And you should have some kind of a consent form for this that has been vetted by your whatever legal resources you have. It is a real time saver for you if you have information that either the patient can access online or you can give to them, because as I mentioned, they will not remember all of what you've told them in the office. If they are receiving a new diagnosis, having disease-specific information for common vulvar conditions is really, really helpful, and we'll talk in a minute about where to find that. I always sent every new patient out with a packet that contained a number of things, including general vulvar care and tips for managing pain flares. I had vulvar diagrams that I would then use a highlighter marker on to show the patient exactly where I wanted them to apply topical medications. I had a colleague who would print out the picture of the patient's vulva from the EMR and use that with a highlighter marker to show the patient where she should apply her medication. And it's really helpful for the patient if they have a trusted list of internet sites and support groups. You really want to vet these, because there's a lot of stuff out there, and many times they can just be really negative. So you want to make sure that the programs and sites that you recommend to your patients are going to be helpful to them and have accurate information. If you're looking for handouts, there is a web-based algorithm which is www.vulvovaginaldisorders.com. Vulvovaginal disorders is all one word, and they have patient handouts there. The International Society for the Study of Vulvovaginal Disease, ISSVD, has their own handouts. Dr. Libby Edwards has a textbook, Genital Dermatology Atlas, that has patient education handouts that she makes available to you and allows you to use without charge. We wrote our own handouts for most of what we did, but however you get them, it's really helpful for you to have those things for your patients. And next is assemble your network of referral consultants. Nobody can do it all, and none of us practice in a vacuum. If you think about it, this unique little subspecialty of vulvovaginal medicine exists at the intersection of a number of different disciplines. We've talked about gynecology and dermatology, but physiatry and pain management and physical therapy are one piece of it. Sex therapy is another piece of it. Infectious disease and oncology is another piece of it. Vulvar manifestations of systemic diseases, and so internal medicine and other disciplines like gastroenterology are part of it. So no one is going to be completely conversant in all of this stuff. And having a network of preferred consultants is incredibly helpful. I will tell you that the specialist that we use the most, hands down, was pelvic floor physical therapy and sex therapy. If we did biopsies, we sent them not to pathology, but to a dermatopathologist, someone who really specialized in skin disease, because many of these things can be really subtle, and you need that level of detective work for a lot of this stuff. We had many patients who came in with vulvar skin disorders that were really obscure and difficult to sort out, and so we did a lot of North American series patch allergy testing. For a lot of our pain patients, Botox and trigger point injections were done by urogynecology because we didn't do them in the office, but there's no reason why you can't get trained in that and do it yourself. We used a local pain clinic and a local physiatrist for people who are having vulvar pain. We were big fans of cognitive behavioral therapy for a lot of our vulvodynia patients. We did a fair amount of work with vulvar Crohn's disease and hidradenitis, and for some of these people with late-stage disease, we would use plastic surgery to do big vulvar excisions of widespread disease. We don't do these by ourselves, and we had at least one excellent and interested plastic surgeon who did the bulk of this for us. And I can't say enough about compounding pharmacies. You need to find out who does compounding in your area. You need to cultivate them. If there's more than one provider, get them to compete for your business and try and talk them down on their prices. There are many times that a medication that a patient may need is not available in a particular form that they needed in a delivery vehicle that they need. You may have to have combinations of medications that are not commercially available. You may need to have things compounded if the commercially available products are too expensive. Compounding pharmacies were just our right hand when it came to prescribing, and you should cultivate that. And you don't have to have somebody right in your town or your backyard. There are national compounding pharmacies that will work with your patients as well. We had lists of consultants in our office for the people who did North American series patch testing, the cognitive behavioral therapists. We did practice in the greater Boston area, and patients came to us from all over the greater Boston area, and they wanted to see a consultant that was close to the town in which they lived. So if you have options to offer them, that makes them more likely to comply with your recommendations. Pelvic floor physical therapists, compounding pharmacies. You need to put together these lists of consultants so that you can find out which ones are going to be most convenient for any particular patient. And then there's certain kind of supplies and equipment that are unique to what we do. Vulvoscope is basically kind of a fancy way of referring to magnification of the vulvar skin. You can use a colposcope for this, but you don't need to, and frankly I find it awkward. Anoscopes are helpful because sometimes vulvar disease is perianal, and sometimes it goes up the anal canal, and it's nice to have one of those short little anoscopes to be able to see a short distance up the anus. You have to do microscopy if you're going to do this work. You have to look at vaginal secretions. And I became acquainted with and fell in love with phase contrast microscopy when I started doing this work. We'll talk about that in a minute. You can't get around doing vaginal pH and saline and KOH wet preps. This is an important part of what you do. You're going to need culture media for a number of things, especially for yeast cultures with speciation and some other point of care testing and herpes and aerobic, other culture media. And if you can create templates within your electronic medical record for common medications and also common medication regimens, some of which can be lengthy and complex, that will be a great time saver for you. We had great big mirrors in all of our exam rooms. We bought them at dollar stores. You don't have to spend a lot of money on this, but we always taught our patients where their disease was, if it was something that you could see, where to apply their medications. It's a wonderful teaching tool for the patient, and many times it's quite reassuring because these patients come in very anxious, and it can be reassuring to acquaint them with their own anatomy and show them that it isn't quite as abnormal as they were imagining. Here's a variety of magnifiers. They can be handheld, they can be integrated into glasses, and the one on the right is a headband magnifier. My husband actually got this for me because he uses one in his garage work. and I also have colleagues who use these kind of magnifiers, but some kind of light and magnification for closely inspecting vulvar skin is going to be necessary because many of the things that you're looking for are very subtle. You're going to be doing vulvar biopsies, and that's almost the only procedure that you're going to do. So you have to have several ways to anesthetize your patients. It is kind of lay folklore that you can't use epinephrine on genital skin. You can. I wouldn't inject it directly into the clitoris, but pretty much anywhere else is fine. And we generally would pre-treat them with something topical and then put an occlusive dressing like saran wrap over it for 15 to 30 minutes before doing the injection of local. And generally, if you have the time to do it that way, the patient is completely comfortable when you do your biopsy and obtain hemostasis. Another thing to do is you can prescribe a 5-gram tube of one of these anesthetics. Which is the one on the left. You can send that tube home with them, or you can prescribe it to them at home, and they can start applying it to the area that's going to be biopsied every 15 to 30 minutes for an hour or so before their appointment, and by the time they get in they'll be good and numb, and then you can just inject the local anesthetic. You will need the equipment to do vulvar punch or modified shave biopsies, and you'll need the appropriate fixative for whether you're doing a common biopsy or whether you're doing immunofluorescence studies. You want to check with your lab and see what they require. And if you're going to be administering intralesional or systemic triamcinolone, be aware that it comes in 2 strengths. The intralesional is the 10 milligrams per ml, and the systemic is the 40 milligrams per ml. And you don't want to be injecting the more potent medication intralesionally. If you're going to be doing trigger point injections or Botox injections, a pudendal block tray has that Iowa trumpet and all the equipment that you need to be able to do that, and is a nice resource. Here is a phase contrast microscope that has a setup for a camera on top of it so that we could take pictures of things that were particularly interesting for teaching purposes. What is the phase contrast microscope and why do you need one? Well, here's the difference. On the left is conventional microscopy and on the right is a phase contrast microscopy. The wonderful thing about phase contrast is that the really relevant cells, the inflammatory cells, the parabasal and basal cells, they glow with these bright rings around them. It's wonderful, and it also kind of gives you better magnification and a clearer picture of what's going on. Now, if you can't afford a phase contrast microscope, there's a little shortcut that you can order so that you don't have to, so that you can retrofit a microscope that you currently have. I don't want to get into lasers because at this time when I'm doing this recording, which is 2020, the jury is still out whether there's sufficient evidence to recommend these as treatments, but there are people who are using fractal lasers to treat vulvar lichen sclerosis and vaginal lasers to treat atrophic vulvovaginitis. So if you have access to these either through a dermatology clinic or a gynecology clinic or whatever, you may be using this as additional therapy. You don't need to start out with this. How much topical medication to use is always a difficult thing to teach patients. I had pictures of a small dab of Vaseline that I then colored with blue food coloring and then rubbed over my hands to demonstrate to patients that I had enough with that little dab of Vaseline to cover both sides of both of my hands, which was 4 times the surface area that they needed to cover when they were treating their vulvar lichen sclerosis or lichen planus. However you can demonstrate for people that they need very little of their topical medications is helpful. Be aware that many of the patients who come to see you are going to have an allergy to fragrance, and that fragrance is kind of the new latex. It is an unfortunate reality that the regular hand sanitizer on the left costs 99 cents a bottle, and the hand sanitizer on the right that has everything that the one on the left does except fragrance costs $5. But also be aware of other allergens: hand soap, lubricant pads, wet wipes. All these things can irritate vulvar patients. We requested that our patients not wear fragrance to their appointments because other patients who would use that room later might be sensitive to fragrance, and that could be a problem. We had laminated pelvic floor diagrams when we were trying to train and educate our patients with pelvic floor dysfunction. And if you're going to be treating patients with vaginismus and with pelvic floor dysfunctions, many times dilators are helpful, and here are some resources for finding dilators and vibrators for your patients, although your pelvic floor physical therapist and your sex therapist may have ones that they prefer as well. Here's a less expensive option. There are other do-it-yourself ways with candlesticks and syringe covers, but generally the kits that you can find that have a variety of sizes online, if you do your homework, you can find the ones that are least expensive. There are lots of aids for patients with vulvodynia. We were fond of this particular cushion that had a cutout in the center of it so that it kept pressure off the vulva, and then the illustration on the right is a bicycle seat that is made for patients with vulvar complaints. And then lastly, we're going to talk about how to optimize finances. I mentioned before that nobody gets rich doing this work, and many times it's really difficult to break even seeing these patients. There's not lucrative procedures that you do for them. The visits are long. It's just hard, and there are other things that make it harder. Steps to successful revenue capture. Do a procedure and evaluation and management review of your practice. If you have access to a coding specialist, have them do that for you. Determine which diagnosis and procedure codes are missing from your routing forms and get them on there. Make that the path of least resistance. And then perform an in-service for all your providers, including one-on-one auditing and training if they need it, because you just can't leave any money on the table. The margins for this work are so slim that you cannot afford to be not billing for things that are billable and doing it correctly. Now, here's a new patient visit, okay? It should be an evaluation and management level 5 because you're going to spend 60 minutes. And in that you have to have 4 HPI elements, 10 review of system elements, past medical history, family and social history, a full body and pelvic exam, and a new problem workup, 4 data points, and high risk. All right. The follow-up visit, the 30-minute visit, which is E&M level 4. 4 elements in the HPI, 2 to 9 systems in your review of systems, 1 of either past medical history, family or social history, 12 or more elements in your physical exam, and 3 diagnosis elements, 3 data elements, and moderate risk, okay? Here's where you get tripped up. It's right there, the 12 plus physical exam elements. If you're doing vulvovaginal work, okay, we have 13 elements in our exam. They're listed there on the left, but the only ones that count for coding purposes are those 4: external genitalia, perineum, and anus, urethral meatus, and vagina. That's it. So you will never get 12 plus elements in your physical exam. And 4 elements is E&M level 2, which is 10 to 14 minutes, which is a lot less than you're going to be spending with these patients. So what's a provider to do? Well, you have to bill on time, on the time spent. And the verbiage that you need in your note is total visit time, either 60 or 30 minutes, and then either 45 or 20 minutes spent reviewing treatment efficacy and impact of condition on the patient's life, as well as counseling and coordinating care related to the issues above. And remember that the minutes reviewing has to be more than 50% of the total visit time. If you put that in your note, you will be able to bill on time, and we did all of our billing on time. Now, common E&M coding errors: not billing as a consultant when it's appropriate, and we'll talk about how to do that in a second. Incorrect level of office visit based on your documentation. Always book to the top of your bill to the top of your documentation. And inadequate use of your time spent counseling and coordinating your care. You know, billing on time. That's really what did it for us. Now, if you're going to be a consultant, you have to have a request for your specialist's opinion or advice regarding a specific problem. You have to make a recommendation based on the findings, and you have to report back to the provider that requested the consult. And if you do those 3 things, then you can bill as a consult. There are, I'm not going to get into the weeds about coding, and I'm not going to pretend that this is the last word on coding, because coding changes all the time. I just want to, in very broad strokes, bring up the places that you want to be aware of, because there are destruction codes, biopsy versus excision codes, blocks, injections, and meds, and use of modifiers, all of which can help you. Modifier 25 is a useful one, and it's one that I used a lot. If you were going to do a minor procedure on the same day as an office visit. For instance, if you see somebody and you see something that you don't like on the vulva and you want to do a vulvar biopsy right at that visit rather than bringing her back, many of our patients traveled long distances to see us. You just bill for the biopsy, but do it as a 25 modifier so that they understand that it's an additional procedure at the same time as the visit, and they don't reject that procedure. Be aware that there are different codes if you are biopsying a piece of a lesion, if you are excising the entire lesion, and there's also a different code if the lesion is malignant. So when you get your results back in a day or 2 and you find out that it's a malignancy, make sure to contact your coder so that they can upcode to that as well. Be aware that simple versus extensive destruction is left up to the provider, but you really have to be careful about how you document it. Make sure that you document enough to justify extensive destruction of lesions. And there are modifiers for if the procedure was particularly difficult. There are modifiers for if you had to abandon the procedure in the middle because the patient didn't tolerate it. And then there are modifiers that you can use if you are operating on 2 different lesions in the same body area. Don't forget, when you're doing injections and blocks, there's a different code for pudendal, inguinal, and genitofemoral blocks. And don't forget that it's not enough to code for just the block. There's a J code for the medication as well. And if you're doing bilateral blocks, make sure that you use 2 units with a modifier of 50. And so if you're doing trigger point and intralesional injections, there's codes for that. Don't forget to use a J code for the medication as well, because your office is paying for that medication. That's billable. You should be doing that. And then this is my final advice. Be patient and stay the course. It will take a while for you to build up the practice of your dreams. And it will be a while from the time that you first decide that you want to do it until you get it up and running. Don't get discouraged. Be patient. Stay the course. Don't be afraid to ask for help. I was quite intimidated when I first took over as director of a long-standing clinic, feeling like, who was I? What did I know? And some very kind people reminded me that my mentor and coworker who founded the clinic started out exactly where I was at the beginning, and over time their mentors and their patients taught them how to do this work. Do not be afraid to network and ask for help. Always have your dream clinic in your vision, but don't get discouraged if it takes you years to arrive there. And don't feel like you have to accomplish everything at once. You may have to start small and add elements as you become more successful. These things take time. Provide regular feedback to stakeholders about performance measures. This is where your job security comes from. So, if you are successful at what you're doing and you can document that, these are the sorts of things to bring back to those folks who make the decision as to whether your program continues or not. And this is really the most important. Always plan for succession. Always be training your colleagues and your replacement. You never know which colleague drops by or sends a patient who might then become really interested in what you do and may want to join you someday. So be generous with your teaching, be generous with what you know, be gracious about helping out your colleagues, and be aware that there's no fellowship program for vulvovaginal disease that you can recruit new providers from. You're it. So teach all the time. And if you're looking for resources, consider becoming a member of the International Society for the Study of Vulvovaginal Diseases. This really is the mother lode of people who do this work, who have the expertise, who have the resources, who have put together programs, who know how to make a budget for this, who know how to help you solve your problems. And membership has its privileges. There's a journal that comes along with that. There's a consultative service for dermatopathology. It's the best money you're going to spend if this is where you want to concentrate your professional time and energy. Well, thank you very much for listening to this presentation.